meeting, but I'd like to welcome everybody, say good afternoon and welcome to the launch of the Quality Network for Prison Mental Health Services International Membership. So my name's Matt Tovey, I'm a consultant forensic psychiatrist, and I co-chair the network with my colleague, Professor Andrew Forrester, who will be summing up at the end of the talks. So just a bit of housekeeping before we start. There may be some time for questions, but I'd ask if people can pop questions in the chat to start with, and then if we do have time, we can change things and ask people to pop their hands up and cameras on. As ever with these meetings, if people could keep their microphones off if they're not talking to save any disruption to the speakers. And I've been told for technical reasons, sometimes it's better to have your camera off if you're having any difficulties hearing the presentations. So why is it that the Quality Network is looking to launch its international membership? Well, we're really keen to learn not only from services in the UK, but also services elsewhere. We want to be able to share best practice, and we think that's best done kind of cross-culturally. And having a platform like this where we might be able to learn from one another, not only in the UK, but across the world, seems to me to be the best way to look to do this. We're consistently trying to evolve with our standards, and the point of what we're trying to do here is to kind of be iterative in our approach to evolving those, as I say, with other services from across the world. The aim to start with will be to have some open discussions whereby services who are interested in join the network will be able to meet with colleagues from UK services who are familiar with the current standards and discuss how they're doing against them, and seek advice as to where they may want to improve things, but also to offer some feedback on what we currently have and where we need to make other changes or considerations to what we currently have. And in time, it is hoped that we're able to offer something more akin to a review. There are challenges with this, and we will be looking to work with other services to think about what this might look like in the future. So today, we first off have Maisie and Kelly from the network who will talk to us a little bit about the network. And then we've got two talks. We've got one from Dr. Andrew Carroll, who's Deputy Chief Psychiatrist in Victoria in Australia, who will talk to us about the top 5 challenges in Australian prison psychiatry. And then we have Professor Mohammed Al-Uzri, our Presidential Lead for Global Mental Health, who will be talking on addressing challenges in international psychiatry. So I'll start by handing over to my colleagues Kelly and Maisie, and then we'll continue with the talks. Thank you.
Hi everyone, thank you, Matt. So as Matt said, I'm Kelly, I'm the program manager for the network. Maisie, would you like to introduce yourself?
Yeah, hi everyone, I'm Maisie, I'm Deputy Program Manager for the network.
We do have a PowerPoint. It won't be long, but I'm going to try and share my screen, and hopefully we can all see this properly. That should hopefully be working now.
Can't quite see it yet.
Give it a minute. How about now?
I can't see it, but I don't know if anyone else can.
Not yet, Kelly.
Ooh. Is that the first technical difficulty of the webinar? Does it look like it's loading anything?
It's just blank for me.
Oh.
Do you want me to try?
You can, yeah. Let me stop sharing. You have better luck.
Has that worked?
Yeah.
Yes.
Yeah.
I can see the PowerPoint in itself, but not the slides that's sharing slides.
Oh. I have put it to that, so I'm not sure. Is it loading or is it just...
It's still on I can see the notes from the PowerPoint slides. Maybe let me just try showing my whole screen rather than just the slides. This has never happened before, so it's all a learning experience for everybody. So let's try this one. How about this? This is my whole screen instead of just the
I
slides?
can see that.
That
Okay.
works. Okay, perfect. So with that out of the way, we're going to talk about the network a little bit and what it is that we offer is. So who are we? So the Quality Network for Prison Mental Health Services is run by the Royal College of Psychiatrists, and it aims to improve the quality of the service provided in prison mental health services. So it was first established 10 years ago, which seems like it has been a long time. And we started with 18 pilot services. It has been growing each year, and we currently have 40 member services across the UK. And it does include male and female prisons, categories A to D, as well as young offender institutions. We are currently on our 6th edition of the standards, and this edition includes a set of standards for services which provide 24-hour inpatient mental health care. And these were published in 2023, and these are currently the standards that we use to assess services against. We also have an established advisory group, and this has representation from a wide variety of professionals in order to ensure that the network meets the needs of the prison mental health services, but also the complex partnership working. There's more information about the network and our standards, and it can all be found on our website, which we can share later as well. So I think that's my bit. I'm going to pass over to Maisie, who will explain a bit more about the international offer.
Thank you. So the purpose of the international membership is to share good practice internationally and also to invigorate practice within the UK and across the membership. I think, as Matt said, we don't want it to be like sort of UK practice is best and we want to share it. It's sort of learning from each other and also improving the UK practice along with that. We wanted to develop an international learning community, and hopefully we're going to continue to see that grow, and working towards service improvement together within that community. Have the next slide, please. Within our pilot year, every service will have a full network induction for all staff, and also there'll be some additional training for reviewers that's held online, and that will be free for all members. Every service will also have an open discussion session, and Kelly's going to explain that in a bit more detail in a moment, but it will be 3 hours long with other prison services to share good practice, challenges, and also develop approaches to sharing the problem solving internationally. So each open discussion review team will have both international and UK based peers, and hopefully that can be a space to share good practice and also to discuss any shared challenges. Each service will also have the option to have a self-review report, so that'll be a space to go through and score themselves against the prison standards, and also have a chance to have that put into a report that we will create just to support the development of high quality patient care. There's also options hopefully in the future to, as we expand the membership, we might offer more of a report that we are scoring the standards for services, but at the moment it will just be a self-review report. For events, we'll also have free places at our online events, so that's the same as the UK-based and UK and Ireland-based membership, and also discounted prices for in-person events for all international members. Our events are opportunities to showcase and celebrate good practice, and so also there'll be space within our events for international members to speak. Kelly mentioned our advisory group, so as part of international membership, there'll be opportunities for our international members to join our advisory group to help steer the direction of the network, and particularly the international membership. And there'll also be opportunities to contribute to our new network bulletin, and also for the patients within services to be involved in artwork competitions.
Lovely. So we'll go through the open discussion. As Maisie mentioned, it is 3 hours. It will be an online meeting. We currently do this via Teams, but it will depend on what sort of format is best for the service that we'll go through the open discussion. So I'm going to be looking at my screen on this side, just because it's bigger and I can see the writing and the timetable a bit better. But you'll be able to see that it is 3 hours, and it begins with 20 minutes with what we call a peer review team introduction meeting. And that's essentially these clinicians from other services that are virtually reviewing the service or having a discussion with the service. We'll just meet with one of my colleagues, someone from my team, to talk about what it is that's going to happen, what sort of things to expect, and what it is that happens through open discussion. So it's just for reviewers. And then there's about 40 minutes for the service that is hosting this open discussion to talk about their service, who is part of the service, what the prison looks like, sort of like an introduction of this is who we are and this is what it looks like on our side. And then there's about 45 minutes for a discussion for achievements and priorities. And this is for the host team to talk about things that they're really proud of, or things that have gone really well. For example, if there's a particular recruitment that has gone really well for a particular role, then there can be discussions about it. And then the review team will be able to then ask questions about it and, you know, share learning, which is what it is all about. There is a break, as we all know. 3 hours in front of a screen is not advised. So there is a little break in between so we can all then come back refreshed to talk about challenges. So then 45 minutes to also talk about challenges, any barriers, any particular topics that the hosting team will be helpful to discuss with other clinicians. First to see if it's a shared barrier or a shared challenge, and also to ask for any ideas, any tips, anything that has worked well for them. In our experience for the last sort of 2 years, a lot of the discussions and challenges has been about staffing and recruitment and any tips and ideas that other services have. And then there is another sort of 15 minutes for any other business, any other sort of areas that anyone wish to discuss, opportunities for more questions, more linking, more networking, more shared learning. That's all we want from this. And we want to make sure that both the review team and the host team have an opportunity to ask the questions and things that they want to find out about each other. That's pretty much what the open discussion is divided as, and it would be great to have sort of topics beforehand just so that the reviewers can plan and be prepared when they attend these sessions. That's pretty much it from it. So there's some information here about how to contact us, and that's our website as well. This is where you can find a lot more information about us. If you have any questions about the launch, please do send us an email, contact us, ask us questions. We're very happy to talk about it. But that is pretty much it from us.
Okay, we hand over to you now, Andy, for the Australian perspective. Thanks very much.
Okay, thanks very much, Matt, and thanks to the Quality Network for the privilege of being able to present today from Melbourne. I will now attempt the sharing of the screen. Allow share. Is that coming through okay?
Yes, yeah, we can see it, Andy.
Brilliant. Okay. So I'm going to talk about prison psychiatry in Australia, our top 5 challenges. And you'll see the logo there of the Centre for Forensic Behavioural Science, which is where I have my academic appointment at Swinburne University. And the first thing to say is that it's that role that I'm speaking in today. I'm not speaking in my formal Department of Health role. So I'm free to say what I like, essentially. And I'd also like to extend thanks to the Prison Psychiatry WhatsApp group, which I'll be talking about a bit later on in the presentation. So I'm going to talk very briefly about the Australian context and give you some facts and figures. 5 key challenges that the WhatsApp group have agreed are appropriate to convey today, and some possible next steps. So the Australian context, as I'm sure you're all aware, Australia has a federal system. So we comprise 6 states and 2 territories, which together with the Commonwealth itself, which has its own separate jurisdiction, means that we've got 9 jurisdictions for 27 million people. Some would say we're a little bit over-governed. Importantly for our purposes today, states and territories set our own laws, and it's the states and territories that fund and run the prisons and public mental health services, albeit with some Commonwealth funding involved as well. So I'm in Melbourne, which is the south part of Victoria there. So let's look at some figures. Prisoners per 100,000. These are the 2024 figures, hot off the press from the Australian Bureau of Statistics. And across the nation, we are something like 6% up on 2023, but that pattern is not uniform. And in Victoria, we've actually had something of a drop per 100,000 due to some more enlightened bail law reform. So our total average is 208 per 100,000, which, as you can see, compares unfavourably with England and Wales, which I understand sits at 134. And even that is the highest in Western Europe. So most of our states and territories sit above that figure. Victoria sits below it. You'll see you've got WA there at 340. It's quite a large Indigenous population, and sadly, Indigenous populations are overrepresented in prisons. And you'll see at the top something that can almost look like a misprint, 1,182 per 100,000. That means over 1% of the Northern Territory adult population is incarcerated, and that figure goes above 3% if we consider the Indigenous population of the Northern Territory. So that is clearly a national disgrace. Let's look now at number of mental health public hospital beds, which includes forensic beds per 100,000. These figures are from 2021. The beds per 100,000 have been declining by an average of 1.5% since 2017, not because beds are being shut, but because the Australian population is growing quite quickly, and the beds are not keeping up with that. So you'll see the figures are generally somewhere between 20 and 30 beds per 100,000, which doesn't compare well with similar countries of similar wealth. So the UK sits at 46, Germany, which is more or less of equivalent GDP per capita as Australia, sits at 128. The other countries that I found in the data that sit below 30, Kyrgyzstan, Cyprus, Albania, Turkey, and the USA. So with that as the background context, what are our 5 key challenges in working in prison mental health in Australia? And these are just from personal experience. They're not in any particular order. There's no huge amount of science has gone into picking out the top 5 challenges. But the WhatsApp group, which now comprises 60 fellow psychiatrists, agrees that these are major concerns. The focus here is on the adult sector. Youth justice has huge challenges in Australia, in some jurisdictions more than others. It's become something of a political football. In Queensland, a new right-wing government has recently come into power, partly on the back of a adult time for adult crime mantra, which was very popular with the electorate last year. It could be argued that the insufficient public mental health bed base and a lack of trauma-informed thinking kind of underpin all 5 of these challenges. So in no particular order, let's look at the first one: lack of access to non-biological therapies for prisoners, particularly those with high prevalence disorders such as anxiety, PTSD and depression. Now, in the community, Medicare, which is a federal, so Commonwealth funded system, largely funds both private psychiatry and private psychology. Doesn't entirely fund them. There is a gap, but nonetheless, people are able to access psychotherapy with a reasonable level of reimbursement from government funds. Prisoners immediately lose access to Medicare funding on the logic that the states are supposed to provide the equivalent services within the prisons. And of course, the prison services are not actually equivalent and are heavily skewed towards pharmacotherapy and management of acute suicide risk. And there still seems to be limited appetite to fund proper trauma-informed therapies, despite the fact that, as in every jurisdiction, there is a huge prevalence of trauma-related conditions within our prisons. Number two, long-term segregation of those with mental illness and mental disorder more broadly. So this means because hospital beds are limited and because services are often very thin on the ground in the prisons, perhaps especially in some jurisdictions more than others. So Western Australia is particularly poorly served in this regard. It does mean that people with behavioural disturbance can be held in segregation in management cell type situations for months and without receiving proper treatment. And even when clinicians do get to see such patients, the assessment can be very compromised by the fact that it has to be done through the trap, through the hole in the door, rather than a proper face-to-face clinical assessment. Eric Monasterio writes a bit more about this issue in a New Zealand context, and the references for this paper will be given at the end of my presentation. And again, Eric makes the point that until we have a proper level of psychiatric beds in New Zealand and Australia, then this problem will continue. A related problem, slightly different, is the lack of pathways and options for people who've become justice involved and have neurodevelopmental and or neurocognitive disabilities. So intellectual disability, autism, dementia, an increasing problem as we incarcerate those convicted of historical sex offences. We end up, each jurisdiction has a significant number of people in indefinite imprisonment situations, despite never having been convicted of a crime because they're permanently unfit to stand trial. And there is, in Victoria at least, and in some of the other jurisdictions, there is very limited, in fact, essentially no secure clinical units in the community for people, say, high risk of violence who have autism and intellectual disability. And so they can often default to indefinite imprisonment, which is a real scandal and one that's hidden and people don't talk about enough. An exception is Kerry Eagle, my colleague in New South Wales, who's done some tremendous research on this problem in that jurisdiction. And again, the reference for her work is at the end of this presentation. Problem number 4, a very poorly integrated care system for people who are in custody. This is probably worse in some states than others. I think Queensland does a good job. Victoria does a fairly terrible job, in my opinion. It's a particular phenomenon in Victoria that after a fundamental restructure of the public service in the 1990s, including rapid deinstitutionalisation, a sort of quasi-privatisation model has infected us, and that has led to significant disintegration. So what we have in the prisons in Victoria is specialist, or sometimes called secondary, mental health services are provided by Forrester, my previous employers, funded by the Department of Justice. So we're still in a situation where prison mental health is a Department of Justice responsibility rather than a Department of Health responsibility. But that specialist service only applies to a subset of prisoners with mental health problems, a fairly small subset. So-called primary mental health services and primary health services, such as general practitioners and some of the psychiatric nurses indeed, are employed by a totally different organisation, largely employed by GEO, which is an American multinational healthcare provider, which I understand is run by a hedge fund based in Florida. So they run primary mental health services. There are then offence-specific therapies by what's called a forensic intervention service. They are they're very good clinicians, and I've met with them and they do great work, but there is no point of overlap between what they do and what the clinical services do. No, totally different files, no proper no organised system for discussions of complex clients, things like that. Similarly with alcohol and drug services, similarly with psychosocial support services, who particularly become relevant when people are approaching release. Then we have a federally funded national disability insurance scheme, which covers not only those with disabilities, but also some of those with chronic mental illness. But again, interface with that system is complex and clunky. Post-release, and I'll talk a bit more about this in a minute, we are releasing our prisoners in Victoria to, if they have ongoing mental health needs, to one of our 21 area mental health services, each of which has its own records, systems, processes and culture. So the kind of assertive, holistic, long-term joined up treatment and support that's really required to assist people with severe enduring mental illness to help them desist from offending is incredibly difficult to achieve. And release planning for homeless prisoners with psychosis is, as you'd imagine, especially difficult. Which takes us to the final point of access to care from general services after release. And, you know, there's probably still no better paper in terms of how this problem was summed up than that written in 1977 by John Gunn, where he talked about banishment pressure from general mental health services towards patients with a history of offending. He wrote, "The view of many NHS staff is that there's a group of patients who are too difficult or perhaps too nasty to be dealt with as ordinary patients. This is the product of two forces, stigma, but just as important, fear in the face of inadequate skills and resources." So we recently had a Royal Commission into all of our public mental health services in Victoria, and one of my generalist colleagues, who's very senior and actually briefly worked at a department, argued in all seriousness for a completely separate part of the ward in his hospital where they would accommodate people who had been released from prisons, because clearly they were deemed to be fundamentally different from their other patients and shouldn't be allowed to mix with them. So again, we see stigma front and centre even in the 2020s. Some possible next steps. Well, to quote Pablo Casals, the cellist and liberal thinker, the situation is hopeless, we must take the next step. And one of the next steps is the work done by the Justice Reform Initiative, which is a terrific organisation, a politically non-aligned advocacy group, an alliance of professionals from diverse backgrounds, include retired judges and retired politicians, driven by evidence that jailing simply is resulting in more offenders, committing more crimes, more disadvantage and more costs to the taxpayer. And the Royal College in Australia and New Zealand is a supporter organisation, and the JRI puts out some great data and some great think pieces and organises a conference every year. In Victoria, one of the things that's happened is the expansion of the role of what's called the Chief Psychiatrist's office into the prisons. So the role of the Chief Psychiatrist has existed since I think since the 1980s, but historically never had any interest or statutory role in terms of oversight of what was happening in the prisons. In the wake of the Royal Commission, that changed, and with our new Mental Health and Wellbeing Act, as it's called, the powers of oversight were extended to custodial settings where mental health and wellbeing services were provided. So there is a chief psychiatrist, and there are about half a dozen deputies, of which I am one, and I am the one responsible for forensic issues, particularly those involving the prisons. But it very much involves a team, and there's other disciplines involved as well as psychiatry. So in the first 18 months, the forensic team within our chief psychiatrist's office has been busy. We've set up an advisory group, which includes a member from our forensic faculty of the college. At the invitation of the Department of Justice, who remember commission the clinical services and actually own the clinical files, so we can only access the files with their permission. At their invitation, we've started to do death reviews, of which there have been quite a number, sadly. We provided advice to them around recommissioning and around quality standards. And occasionally we've got involved in particular inter-service disputes around particular patients. In terms of what our psychiatrists are doing, I like this quote from Scott Harden, who's a very senior child and adolescent forensic psychiatrist in Queensland. It's coalitions of like-minded individuals that cause change to occur. And within our forensic faculty, we've been trying to develop such coalitions in recent years because there's a lot of change that needs to occur here. We will be encouraging relevant services to link up with the quality network. We're setting up a prison mental health advisory group within our forensic faculty. Collaboration, particularly with general mental health services, is a theme of various relevant conferences this year, and there's a list of those at the end of the presentation. We're attempting to draw on international best practice, which is what today is all about. And I'd like to give a shout out in particular to Andrew Forrester and to Sandy Simpson, who've been incredibly helpful to me in my new role as Deputy Chief Psychiatrist here, been very generous with their time and thinking in sending me ideas for how we can improve things here. And most recently, Claire Crowell-Rees has been incredibly helpful in sending papers and thoughts about trauma-informed therapies within prison contexts, which has been helpful for me to kind of attempt some culture change here. And finally, discussions of ideas on our WhatsApp group. So feel free to join us, please. Go to bit.ly/prison psychiatry with 2 capital P's, or you can use that QR code. We've got over 60 participants at the moment from all states and territories, New Zealand and a couple from America. It's a fairly low-key, informal entity. There's no oversight from our Royal College. We don't discuss individual patients, but we do discuss issues as they come up and share ideas. So that's the talk. My email is at the bottom there, and I'm very happy to hear from anybody about any of this stuff. I've listed some interesting conferences there, including one in Tuscany in September, which is actually run by Swinburne University, but is nicely for us is based in Tuscany. And then there's one in Melbourne in August and Alice Springs in June, run by the Justice Reform Initiative. And then there's references to Kerry's paper and a short paper that I wrote with Adam Brett in the BJ Psych Bulletin. And then there's the Justice Reform Initiative website. So I will now stop sharing and hand over. Stop sharing. Yes. Okay.
Thanks very much, Andy. I think we've probably got a minute or two for any questions, if you're happy to take them, if anybody has any. Don't know if any of the audience want to pop their hand up. Andrew, your hand has popped up.
Hi, Andy. Thanks very much for a great talk there. I'm interested in a question about segregation and thinking about the Mandela rules, because as you were speaking about the use of segregation for people with mental illness, I just had a quick look at the relevant bit of the Mandela rules. And what it says is that it should be used in exceptional circumstances only, short-term only, and that it's prohibited in cases of mental or physical disabilities, especially where their condition is exacerbated by segregation. That's pretty much exactly what it says. So I suppose I've been thinking about this off and on over time. Why is it that we have these international rules and regulations and guidelines, perhaps we call them, that we don't then apply in our nation states? What's going on there?
Yeah, look, it's an interesting one, isn't it? I mean, and we can, ultimately, of course, it comes down to lack of options and lack of resources. But I think the other thing that can go on and that can hide this problem is sometimes almost Orwellian language, whereby, you know, you have your close supervision unit, or, you know, your special needs unit, which is essentially segregation by another name. I was involved in a case of a man who was found permanently unfit to stand trial, who effectively never left his room for 2 years. You know, literally didn't shower for 2 years. Turned out to have, actually, I thought, hebephrenic schizophrenia, but and when he actually got onto antipsychotics, things got much, much better for him. So that type of thing is going on, and I think partly that, you know, that the Orwellian language that goes on doesn't help, and the reluctance of services to actually own up to the problem also doesn't help. But, you know, fundamentally it's about the usual things of resources, skills and such like. You know, nobody, and this is what, you know, some of the things I read about trying to put the blame onto prison officers for being nasty, I think completely misses the mark. You know, that's not what this is about. This is about society not owning this problem at quite a fundamental level.
Yeah, thank you. Thanks.
Okay. Well, thanks very much, Andy, for that. And I think if we can, we'll now move over to Professor Mohammed Al-Uzri's talk. Good afternoon, Professor.
Good afternoon. You. I mean, thank you very much for the invitation to join you today, and a couple of declarations in advance. I'm, because of the storm, I've lost my internet, so I'm joining from my phone. I'm hostage to whatever happens to my phone. The second thing to declare, I am not a forensic psychiatrist. I've had a year in my higher training in forensic placement, but I claim no expertise in forensic psychiatrist. What I want to share with you today is a little bit of our experiences in international psychiatry, and I'm really pleased that you're launching this quality network, because forensic psychiatry is something we get asked about it whenever we do our international work. We talk about the college and its different faculties and the expertise within the college. In fact, the forensic faculty have very kindly delivered for us a module on forensic psychiatry in one of our major collaboration in Ghana, which I just kind of finished in November of last year. So I am not gonna tell you anything about forensic, but I'm gonna share with you what is it like to work in international psychiatry, and some of the challenge. I'm sure there will be more, but just really to give you an idea about those challenges and how do we deal with them. Can you please move to the next slide? Just a gentle reminder, we are not a UK only organization. We are a global organization. We are a professional membership organization across the world, and 20% of our membership are based overseas, and we have 6 international divisions divided geographically. Next, please. Just a reminder of why we are a global organization, clearly stated in our vision. Our commitment is not just to the UK, but for people of all ages around the world. And next, please. Moving into challenges. Like I said, there are some of the challenges that we come across. So one of the first things is that whatever we do internationally, how do we know it has the right impact? And second, you will hear whenever you talk about international work, sustainability. Okay, after you've done your work, how are you going to make sure that this work have a lasting impact. One of the challenges is ownership. So we can come as the expert, and we claim to know a lot, but there is a risk with that. I mean, for a valid reasons, we can claim those expertise. The downside to it is that colleagues, especially in less resourced places, well, they don't feel the ownership of this collaboration and becomes a matter of dependency, which I highly don't recommend. The other thing is that we come from different parts of the world, but at the same time, we are not fully aware and knowledgeable about the culture, the landscape of that particular world of the world. And so important that we partner. And so we have a good partner there to work with. There is the small matter of logistics and fundings. Every work needs funding, and international work is no exception. And we will come into how to do that. There's another challenge we as a college have, which is consistency. How do we deal with issues across the world with some consistency and not respond to one issue favorably and not to the others? And that's another challenge that was put forward to us by our membership across the world and some of our colleagues and partners. Can we move into the next stage? The next slide, please. So let me jump first into ownership. So what we try to do is make sure that we respond to the local needs rather than imposing our own model of how to work. And like I mentioned earlier, we are there to build capacity, not to create dependency. So they are dependent on us, and they were waiting for us to tell them what to do. We never go to any country and say to them, this is what you have done, what you have to do. It's always on request from colleagues in different parts of the world and say to us, we need to collaborate on that. And that's how we respond, mindful of the historical issues and so on. We respect local cultures, but at the same time adhere to the college values, and we make sure that we are not breaking any of or acting outside the college values. And I will use examples of how we do that. Next, please. Impact. We have plenty of colleagues who are good-willing, and they are happy to contribute and take part in good work. The problem with that, all this goodwill and good work can really have some unintended consequences when it comes to delivering that work. And that's why we stopped any individual volunteering or work. And we always, we have an established volunteer scheme with governance and support. And we start for every project or every country, we establish a lead volunteer. So the idea is that nobody works alone. And that's how we make sure that we have better impact rather than just individual intervention. Also, whatever we do, it has to be quality and evidence-based, based on evidence-based resources. And that's where the college comes in, the faculties comes in with all their expertise in the field. And with our collaborations, we provide access to college resources and leaflets, which you would be familiar with them. Next, please. We have a wonderful resource of public health leaflets. They are evidence-based, accessible, up-to-date, and they are translated into very large number of languages. And we are always prepared to expand on that. And we use this. They are free access. We share with our colleagues and service users across the world. Next, please. Sustainability, as I said, it's so easy to just go do something and come back and feel very good about it. But how do we know whatever we've done, the impact is going to be sustainable and continue? And that's why we restrained ourselves from delivering training events without supervision and follow-up. So we always talk about a project of collaboration rather than delivering an event. And whenever we work, we make sure that the training that takes place in the context or with links into the local services. And again, I will provide an example of that. Next, please. We are a charity, and let's not kind of beat around the bush. We are very well resourced as a college, thanks to the membership and the valued membership of the college and all the activities that the college have done. But we are not a funding body. And as much as I want to give all my membership fees to international work and help, that is not a view shared by everybody or the membership. And I have to respect that. And on that basis, we agreed that we will never engage in a project without having a proper resources and funding for it. And this is where we come up with this model, which we call the three-way partnership. So we have a host who would like to approach us to collaborate with, and we have wonderful colleagues in the college who are prepared to be a volunteer and provide their expertise. However, we need a third party that is based on the ground. They know the area, they know the landscape, and at the same time, they can provide the logistics and the funding. So we as a college stick to our strength, which is the expertise and the experience of our membership that we can share with the colleagues across the world. Next, please. So I'm going to use some of those examples, that projects that we have worked on, to demonstrate how we address those challenges and adhere to our principles and values. So this is an example of a collaboration between the Iraqi Red Crescent Society and the college. It is funded by the Red Crescent hybrid model. We have some people on the ground, and we have colleagues from the UK joining in. And this is to upskill primary care worker with the doctors working with displaced population in Iraq, to just upskill them with mental health skills. And we delivered that, but that didn't stop. It is followed, because as we know, one training event never kind of teach you a lot. But to be able to consolidate that learning, we provide supervision session, follow-up from the training. And it is linked into the mental health specialist services. So when we delivered that training, we didn't deliver it alone, but in collaboration with the local mental health services. And then we were supervising our trained colleagues as they are cascading this training. Because as we know, one of the best way of consolidate learning is that when you teach yourself. Next, please. Another great example of the collaboration, and this is where we are governed or guided by the needs, local needs. And these are two projects in Africa, very different. So it all depends on the asking, and this is where the ownership comes. In Uganda, they have a big problem with refugee and accessing the basic mental health services. And that's why the focus more on training primary care worker on image gap to upskill their clinical skills in mental health. While in Ghana, the ask was different. It was a request to help develop. They have an established training program, but they wanted some upskilling with some of their subspecialties, namely forensic addiction, old age, and camps. So that was different, where we worked with the faculties and developed modules based on the college resources and the expertise of our membership, and we delivered that. And that was funded. The third party is THET, who funded this program of collaboration. Next, please. Another example of this international collaboration is in Palestine, where we started with providing supervision of residents who, a small number of residents, they are training to become a psychiatrist, but they don't have enough faculties to train them. And that's where the college comes in with their volunteers and delivering the sessions required in their training on online sessions. This collaboration was funded together with, in collaboration with the mental health services in Palestine, and it is funded by an NGO, Medical Aid for Palestinians. And it expanded as the relationship developed. And this is one of the key issues, is that in international work is so important to develop the relationship. And as we all know, once you establish a trust and a relationship, you can really expand widely in areas of collaboration. So we work together on the child and adolescent services strategy. Our chair of the ECT committee of the college have done wonderful work helping them with the ECT services modernization. Our assessment and exams team have helped with the assessment and curriculum update. And we did with the volunteers, some work on caring for the carers with focus on children. Next, please. Final point, consistency. As I've mentioned, as a college, we are an international organization. Our membership across the world, whatever happening across the world affect us. We can't stay away from that. And we have been criticized for having different responses to different events across the world. And that's why we developed an emergency response plan that kind of structured the way that we respond to crises, man-made or natural, that happening all the time across the world. And that was well received by a number of organizations, including the Academy of Medical Royal College, as an example of how to respond to requests for support with a crisis. Next, please. What we don't do, in a nutshell, without taking so much time, we have to adhere to the college principles and values. We don't put our volunteers, our members, to any risk, and we follow the Foreign and Commonwealth Development Office advice when it comes to traveling. Lessons learned. So very important to be consistent. Our fellows and members are very happy to, willing to volunteer with their time and expertise once we provide them with the right structure and support. Collaboration, it's whatever we do, it has to be in partnership with stakeholders, especially stakeholders on the ground. Make sure that we have a real impact. To be able to sustainable, and it has to be an effective operating model, and that's why the tripartite partnership model that we use. And never to forget that it's a two-way learning. Whatever we give in terms of learning in those events, we acquire in terms of experience and bring back. Next, please. Thank you very much for listening.
Well, thank you very much for that talk, Professor, and I'll hand over to my colleague, Andrew Forrester, to sum up. Thank you.
Thank you very much, Mohammed. Thank you, Mohammed and Andy, for speaking here today, and to Kelly and Maisie for speaking earlier. We're just into the last few minutes, really, of the webinar. But I just want to say a few things before we close. I mean, I think that there are good reasons for us to think about this international offer today. and I've taken some notes as we've been going along. One, I think, is about ensuring human rights compliance, particularly the Mandela rules, which I spoke about before. Every time I go back to the Mandela rules, I think that they contain most really of what we need, and we shouldn't be surprised about that. It's just that our sort of difficulty in implementing them within our nation states is apparent as we go on. It's also, I think, about international learning through peer review reports, the advisory group, and learning events as we go along, such as webinars. And of course, we have our international now conference that we have once a year. I think it's also about ensuring that standards of provision are refined and developed over time. And that means getting into the detail of things like the levels of provision within particular professional groups, what service design should look like, for example, in different types of prisons, and the actual nuts and bolts of what happens day to day. So what is provided within screening, for example, what is provided out of hours in certain prisons for mental health support, physical health support even, what pharmacy provision looks like, what nursing provision should look like. I think that these are the sorts of things that we can get to when we think about standards. But I also want to mention some of the international challenges. Andy, you've touched on a few of them already. I want to think about overcrowding, bullying and coercion, which I've seen a lot of in my prison clinics over the years, the illicit economy, drugs, of course, being endemic within most of our prisons, self-harm and suicide, violence and homicide within prisons internationally, pre-trial detention, of course, which happens in many states of the world, people being held for perhaps years, even reports of people being held for more than a decade at a time without being brought to trial and convicted. Political prisoners, of course, which happen in parts of the world, and the death penalty, which happens across the world. Something like 25,000 people in any given year, I think, are subject to the death penalty in different parts of the world, or maybe held awaiting the death penalty. I think we've also, it's incumbent upon us to think about recruitment and retention in this difficult area. We think about burnout, and we think, of course, about moral injury, which I think affects many people as they go on in careers in this difficult area. But yet, alongside the problems, there are also potential solutions, and I think we've touched on some of these today too. Peer review and support, I think, offers a lot and a good way forward. I think an international environment to share good practices is a great thing, potentially. And that means both in terms of research and in terms of what clinical services should look like. I think we can think of this as a place where we can solve problems together, putting our heads together and think about solutions to difficult issues as they arise within individual nation states and individual services even. But always I would make a plea that as we move forward, we have our mind consistently on improvements and consistently on, as Andy said, how we take the next step, even when things might seem hopeless. Just a quote to finish off now from Martin Luther King: "You don't have to see the whole staircase, you just have to take the first step." Thank you, everybody, for attending here today. It's now time for us to close. We're grateful that you've come. We hope that you keep in touch with us as this project moves forward. Thanks again to our speakers, and goodbye for now.